Is it now? I think it
Yes.
is now. Okay, sorry about that. Okay, so let me get back here. Okay, are you seeing cardiovascular system assessment? Kathleen?
Yes, we see just your slide now.
Just the slide. Okay, just want to make sure. Okay, so when we start our assessment for the cardiovascular system, we are going to start with the patient history, which is what you generally start with when you do any assessment. And so the focus for our patient assessment is we're going to be obtaining information about their risk factors and any symptoms that they have of cardiovascular disease. So we want to start with our non-modifiable risk factors, and those are simply risk factors that are uncontrollable. So when you think about that, you want to think about their age, gender, what their ethnic origin is, and also if they have any family history of cardiovascular disease. You also want to think about and ask them about any chronic diseases or illnesses that they have. They may have coronary artery disease. Diabetes is a big disease that goes along with heart disease, because adults that have diabetes and they have heart disease, their death rate is 2 to 4 times higher than those without diabetes. So it's very important to find out about their history of any chronic illnesses or diseases that they might have. Now, when we go on to modifiable risk factors, of course, those are things that they have control of, that they can modify. Those are going to be personal lifestyle habits like smoking. Remember, when you ask a patient about smoking, you need to document that in PAC years. Obesity, if they have a BMI greater than 30, that means that they fall into that obesity range. If they have a sedentary lifestyle or they're physically inactive. And then you also want to think about psychological variables as being a modifiable risk factor. And so when we think about the psychological variables, you want to think about highly competitive people. They're hostile or they're angry. They have that type A personality. Those types of personalities can make patients more vulnerable to the development of heart disease. So you need to keep that in mind as well. And then any medications, you want to make sure you know what medications your patient are taking. As far as prescriptions, you want to see what recent prescriptions they're on as well as current, and also any over-the-counter medications. And with that, you want to include your herbal or your natural products. Make sure you find out about any sensitivities to medications, any allergies, find out what their reactions are, you know, like nausea or rash. And then it's really important to find out whether they've ever used cocaine or if they use any IV street drugs. And when we start talking about endocarditis, you'll see why this is important. You also want to find out if they've had any previous treatment for cardiovascular disease. When we're talking about nutrition, which we will focus on later on this afternoon, you want to have them do a food recall and a fluid intake over the last 24 hours, kind of to see if they have any dietary restrictions, do they take any supplements, and then what is their alcohol consumption, because alcohol plays a part in cardiovascular disease as well. And then moving on to family history and genetic risk. The cause of death of an immediate family member and the age of their death, that is a major risk factor for cardiovascular disease. So a positive family history of coronary artery disease in a first-degree relative, that could be a parent, that could be a sibling or a child. That's a major risk factor. It's considered more important than factors like hypertension, obesity, and diabetes. So make sure you find out about their family history and their genetic risk. And then social history, this is going to include information about their living situation, household members, what type of environment do they live in, is there smoking in the home, What is their occupation? What do they do for a living? It also helps identify if they are not able to pay for their medications, maybe some prescriptions that their doctor has prescribed, they're not able to afford those. And then again, back to their job, does it involve physical labor, exertion such as lifting heavy objects? Is it highly stressful? Does it require them to be outside in extreme temperatures, hot and cold? So those are just some different things that you can ask about their social history. Okay, so moving on to their current health problems, you're still going to be doing your patient assessment, interviewing them. You need to be sure and ask about pain. When we ask about pain, make sure you find out about the onset, the duration, intensity, frequency, location, quality, and any relieving factors they have. It's really important to cover pain when we're talking about the cardiovascular system, because chest pain is the most common symptom of heart disease. And so let's go ahead and talk about the major symptom of chest pain. If you want to look in your IGGI book, it's on page 650 that describes the different types of chest pain that patients might have. So when you're assessing the patient, you want to differentiate the pain between pain of anginal pain and myocardial infarction pain. A lot of times patients will describe their pain as a discomfort. They may describe it as indigestion or squeezing or a heaviness. And so you need to make sure you get from them how they're describing their pain. They also may have dyspnea. DOE is dyspnea upon exertion. This could be an early sign of heart failure. So you want to make sure they describe their dyspnea. Sometimes the dyspnea is the only symptom that women have when they have cardiac disease and they're being diagnosed. So remember, not all symptoms of cardiac disease, not all patients are going to experience anything the same. Orthopnea, that is when a patient's lying flat and they feel like they can't breathe, so they have to sit up in bed to breathe. So your patients might have that as well. And then P&D is paroxysmal nocturnal dyspnea. This is when your patient develops pulmonary congestion after they've been lying down for several hours, and then they wake up, feel like they're suffocating, they panic because they can't breathe, and then they have to sit up to be able to breathe. So that is what P&D is, paroxysmal nocturnal dyspnea. Patients may also complain of fatigue. They also may have palpitations, and they could describe this maybe as a fluttering or an irregular heartbeat. They may also have edema, which would cause them to have weight gain. They could also have peripheral edema. This would be fluid that is accumulated in the legs and the feet. Patients may also have syncope. This is where your cardiac rhythm disturbances come in. A lot of patients are admitted for observation with syncope, and it could be maybe the result of a dysrhythmia. And also extremity pain. It could be, there's two conditions that would cause extremity pain. That could be ischemia from atherosclerosis, or it could be venous insufficiency. There's more detail about that on page 651. And then if your patient has extremity pain, remember to have them describe it. Did it come on, excuse me, suddenly or gradually? You know, how long does it last, etc. The next slide is, I know Kathleen has pointed this out, but the best indicator of fluid balance is going to be weight. Remember that 2.2 pounds is equal to 1 kilogram, and that is equal to 1 liter of fluid. So that's quite a bit of fluid. So that's why it is important, especially if your patient has heart failure, we do daily weights for your patients. Okay, so let's start with the physical assessment. You're going to just generally look at your patient, see what they look like. You're going to note their skin color. Are they in any type of distress? Their level of consciousness, their position, verbal responses. You're going to notice that patients who are having trouble breathing, we've talked about this during our respiratory lectures, they're going to be leaning forward to breathe. When you ask them questions, they may answer you in 2-word sentences or answers. They're going to be very brief with their verbal responses, so make note of all that. So when we think about skin, of course, you're going to look at the color, and you're also going to check temperature. And remember, when we are checking temperature of skin, we use the back of the hand, the dorsal side of the hand, and you're going to assess for symmetry, touching different areas of the body equally and seeing if the skin temperature is the same. You're also going to assess circulation in the nail beds. You can also look for the color of the mucous membranes and the conjunctival mucosa in the eye as well. You know, normally the skin is going to appear pink and warm. Patients that have decreased perfusion, their skin is going to feel cool. It's going to be pale, could be moist. They may be a little cyanotic. That could be kind of a blue color from low oxygenation. They could have peripheral cyanosis, which would be just their cyanotic maybe in their extremities. They also may have a rubor color, and that is R-U-B-O-R. That is a dusky redness, and we'll talk more about that later. That could be in the lower extremities in the feet and ankles as well. So then moving on to the extremities, you're going to look at the hands and arms and the feet and the legs. And you're going to note skin changes. You're going to note skin mobility and turgor. A lot of times this is affected by fluid status. Your patient could be very dehydrated, excuse me, or the aging patient, they have reduced skin turgor, so they may not have a real quick skin turgor. And then also extreme edema, that also decreases skin elasticity. You also want to note vascular changes. This would mainly be in extremities. They may have muscle fatigue. They may have discomfort, numbness, pain, coolness. They also may have loss of hair distribution on their legs, and that would simply be from a reduced blood supply. We talked about the clubbing of fingers. When your body is chronically deprived of oxygen, you will note the clubbing of the fingers. And then on to edema. I think we've already talked about edema. No, maybe not. Edema, you may see that bilaterally at the legs. You may see more edema in the abdominal area. If you see edema bilaterally in the legs, that could be indicative of heart failure. It could also be a chronic venous insufficiency. You may also see dependent foot and ankle edema. Sometimes swelling is a result of medications. Some antihypertensive medications can also cause swelling, so that's why it's important to make sure you know what medications your patients are on as well. And then blood pressure. When we talk about hypotension and hypertension, your hypotension, that could be related to the postural orthostatic hypotension. This occurs when the blood pressure is not adequately maintained, when a patient is moving, maybe from a lying to a sitting or standing position. And so you all know how to take a orthostatic hypotension, blood pressure, orthostatic blood pressure. You want to do it with them lying, sitting, and standing. Wait a few minutes in between and note a drop. Usually it's about 20 points when you would be able to say that they have postural hypotension. Some causes could be their medication. It could be a blood volume decrease. Maybe your patient's been on prolonged bed rest, or it could be their age. So keep that in mind when you're doing your physical assessment. Okay, so next we're going to do inspection. You can just inspect the chest. You want to note any pulses or movements. You shouldn't see any movements across the chest. It may be with the exception in the area, the mitral area, when you are listening to the apical pulse. Sometimes you can note movement there. Then you're going to auscultate for your heart sounds, just kind of a review. A normal heart sound, the first sound is the S1. And the picture here shows you that it is the tricuspid and the mitral valve is closing. Then the second sound you're going to hear is the closing of the aortic and the pulmonic valve. So you should hear a S1 and a S2, so it's a lub-dub sound. Any other sounds you hear will be abnormal sounds, and I've listed those under auscultation, but don't get caught up in the abnormal sounds. Just make sure you understand normal heart sounds. Now, if you have trouble hearing the heart sounds, you can always have your patient, if they're sitting up, you can have them lean forward, or you can also have them turn on their left side, and that will put the heart closer to the chest, and you might be able to hear better. Okay, you also need to make sure you do a psychosocial assessment. Patients, maybe they're going through a major life crisis. Patients with heart-related illnesses, whether it is an acute state or whether it is a chronic state, it is a major life crisis to them. Patients, along with their family members, they're also thinking about death, because when people think of cardiovascular disease, that's the first thing they think about is death. But they also may have fears of pain. Having cardiovascular disease may give them a disability. They may not be able to work anymore. So that would cause them to be physically dependent on their family. So there's all kinds of things that come into play when patients are diagnosed with cardiovascular disease. So then we need to focus on our coping behaviors. And remember, coping behaviors, those are going to vary among patients and families. Patients who feel helpless, they may be disorganized, they may have lots of fear, they may have lots of anxiety. So you need to kind of drill down to see what they're trying to cope with. Maybe ask them, you know, have you ever encountered this situation before? You know, how have you managed previous situations? And this kind of helps reassure them. It kind of makes them think, well, yeah, I did get through that situation before, and this is what I did. So this is a way that can just kind of help patients and families cope when they're having difficulty in that area. Denial, that is a huge coping mechanism. It's very common and very normal for patients who are diagnosed with cardiovascular disease to have denial. This is usually the first defense mechanism that comes into play. Patients may deny that they have cardiovascular disease, or they may say, well, yeah, I had it, but it's gone. Or they could be extremely happy. There again, that denial comes into play. So just remember, a lot of patients are in denial. And then patients along with family members have a lot of anxious feelings. They're going to be not sure about the future. They may have disagreements between family members and patients. A lot of patients with cardiovascular disease, a lot of times they don't want to, if they're having trouble coping, they're not going to follow and adhere to their medications and any appropriate follow-up care that they're supposed to be doing. And so then that's going to cause a problem between the family members and the patient. So just remember, a psychosocial assessment is extremely important, and it may have a lot to do with the way the patient follows up with the doctor and adheres to their plan of care.
Julie, we have a question.
Okay.
Do the students need to know the order of blood flow through the heart? Like
no. No.
Okay.
That is something that it might help them understand the different cardiac diseases that we talk about, but I am not going to test them over. That's something that they kind of already should know from their anatomy and physiology. So if you're not sure about that, you might just kind of refresh your memory. It might just help you understand MIs and heart failure and those types of things more.
Thank you.
Am I talking too fast?
Everybody keeping up?
Everybody's staying with me? I can't see anybody, so
yeah, you're doing good, Julie. Keep it up.
Thank you. I feel like I'm talking to my laptop, and that's so. Okay.
You all can probably hear her sweet, quiet little voice better now.
Yeah,
It's
because
almost lulling me to sleep.
Oh. Okay, so let's talk about some laboratory assessment. This is on page 656 in your book, your Iggy book, chart 33-2. This is probably a new lab for you. It's a troponin. And what troponin is, it is a myocardial muscle protein that is released into the bloodstream anytime you have any injury to your myocardial muscle. So troponin should not normally show up in healthy patients. Anytime you have a rise in that, could be indicative of cardiac necrosis or possibly an MI. When doctors and some nurses refer to troponin, they may not refer to it as troponin. They may call it a cardiac marker. So just know that a cardiac marker includes troponin. Most facilities have a troponin T and a troponin I. A normal level is going to be less than 0.03 nanograms per milliliter. A nanogram is just a unit of measurement. And so what happens when you have myocardial muscle protein released into the bloodstream, that is going to be the result of an injury. And the reason troponin is a really important lab work to look at, other than it is an enzyme that's released to myocardial damage or injury, it has a wide diagnostic time frame. So it's very useful for patients who come in several hours after they have the onset of chest pain. You'll find that when patients have chest pain, they'll sit at home and they think, oh, it's just indigestion. Oh, it's my mind. I really am not having this chest pain. And so sometimes by the time patients get to the hospital, to the ER, it might be 2 to 3 hours after they started having chest pain. So troponin can be detectable in the bloodstream for a few hours up to 7 days after the symptoms of the myocardial damage. So those are a couple of reasons why it's pretty indicative and a pretty good marker that you need to look at. So troponin, usually it will rise 2 to 6 hours after a patient has an MI. It will peak about 15 to 24 hours after the MI, and then around 5 to 7 days, it will be returned to normal. Now, when you see troponin ordered, it's going to be ordered as a serial lab order, which means it's usually ordered every 6 hours times 3. So that means when a patient comes to the ER, they're going to draw troponin. 6 hours later, they're going to draw another one, and then 6 hours later, they're going to draw another one. That way, the doctor can see, is that troponin going up? So does that mean they're currently having an MI, or maybe it's going down? Maybe they previously had the MI and now they're on their way back down. So just keep that in mind when you see troponin. The range, or the normal range I gave you, is what Iggy Book says. Make sure you look at whatever facility you're at. Their normal range might be a little bit different. Okay, we also want to look at serum lipids. If those are elevated, those are considered a risk factor for coronary artery disease. And so those are going to include your cholesterol, and it is a fasting blood sample. Normal is less than 200. Your triglycerides, those are going to be between 40 and 160 for men, and then between 35 and 135 for women. And then also there's your high density lipoprotein, which is your HDL. Remember, that is a good cholesterol. It appears to be protective for the heart. And so for men, for men is more than 45, and for women above 55. So remember that HDL is good, so the higher that level is, the better. And then the low density lipoprotein, the LDL, that is the not so good. If you have an elevation there, that could also be indicative of coronary artery disease. And you want that level to be less than 130. And remember, all this is according to IGI. It could be different at the facility you're at. So some other lab work that could be with the blood and the urine. And the reason doctors do all these tests are to establish a diagnosis. It also helps them to detect concurrent disease. It also helps assess risk factors, and it also helps them monitor the response to any treatment that they have done for their patient. Homocysteine levels, that is an amino acid that's produced when proteins break down. If this is elevated, it could be a risk factor for the development of cardiovascular disease. High sensitive C-reactive protein, this is a marker for inflammation. This does not relate just to cardiovascular disease, but it could be a marker. Microalbuminuria, this is where small amounts of urine, small amounts of protein are in the urine. This has been shown to be a clear marker of endothelial dysfunction in cardiovascular disease. This is usually screened annually in patients if they have hypertension, diabetes, renal disease, those as well. Blood coagulation studies, you all should be familiar with these. These evaluate the ability of the blood to clot. These are more important for patients with a greater tendency to form a thrombi. If patients have AFib, if they have prosthetic valves, or if they are diagnosed with infective carditis, they're more likely going to be on blood thinners for life. And so then these are the lab works that you would use to monitor those. So the PT-INR, it is used when you're initiating and maintaining oral anticoagulants. That's going to be your warfarin or your Coumadin. INR is the most reliable way to monitor the Coumadin therapy. Your ranges, again, are going to range very dependent upon the facility. Normal range for an INR is 1. Some physicians like it to be a 2. And those would be checked before the patient is discharged from the hospital. They would be on heparin first, and then they would be switched to the warfarin or the Coumadin to do at home. A PTT, partial thromboblastin time, this is also assessed for patients that are on heparin. ABGs, I think we covered that pretty clear in respiratory. And then fluid and electrolyte balance. I'm sure Kathleen covered this when she did her fluid and electrolytes, but it's essential to have a balance in your fluid and electrolytes. Patients will have cardiac manifestations if there's an imbalance in their fluid or their electrolytes. Know that with hypokalemia, that can cause electrical stability in the heart. It can also be the result of ventricular dysrhythmias. So just make sure you know what those levels are, and if they're a little high or a little low, know that it can affect the cardiac system. H&H, well, let's see, erythrocyte count. Let's go to that one real quick. Your erythrocyte count, your red blood cell count, that will increase with heart disease because your heart is trying to compensate for decreased oxygen. So anybody that has cardiac disease may have an increase in their red blood cell count. H&H, you know, hemoglobin and hematocrit, I'm not going to cover that one. And then leukocyte count, your white blood cell count. It could be typically elevated after an MI, and then also in different infectious and inflammatory diseases of the heart, the infective carditis and pericarditis. So there's lots of lab work that will pertain to cardiac disease. You probably won't see all these, but just try to be familiar with them.
Julie, how in depth do they need to study on the labs? Like, do they need to know normal ranges or?
The main ones that they need to focus on would be the PT, INR, PTT, and all the ones below that. On the electrolytes, you know, it's important to know normal ranges for potassium, sodium. Those are the two main ones that they would need to know.
Also, there was a question about cholesterol. What do they need to
They
know?
need to know the normal ranges, and I think it's probably on the page I told them about, on page 656, maybe. The cholesterol, triglycerides, HDL, and LDL.
Another question, do they need to know how the lab levels affect the cardiac system in terms of what they see on the EKG change?
No, when we talk about EKGs this afternoon, I don't want you to come to skills thinking you're going to learn how to read an EKG, because you're not. And that is a whole class in itself. We're going to learn a little bit, but remember, we're just learning the basics. And so it's going to be a very basic learning on EKGs. So just mainly know, like with potassium, if you have a low potassium, what is that going to do? If you have a high potassium, because potassium is the main one that is going to affect your heart if it's low or high.
That covered everybody?
Okay. Are we good? Okay, so some diagnostic tests that you may see. Of course, you're going to see a PA and lateral chest x-ray. This helps the doctor with the size. It shows a silhouette of the heart, position of the heart. You can also see cardiac enlargement, which would be indicative of heart failure, pulmonary congestion. A lot of times patients that come into the hospital that have cardiac disease or that have had an MI, they're going to have a central line, so you can see central lines through that as well. An angiography or an arteriography. This is an invasive procedure that involves fluoroscopy and the use of contrast media. Usually these are used with an arterial obstruction. Make sure your patient, you know what your patients, if they're allergic to any iodine-based contrast, because that's what they will be giving them if they do that. Don't focus a lot of time on the angiography or the arteriography, but let's talk about cardiac catheterization. Remember, cardiac catheterization is the most definitive test in diagnosing heart disease. I know the students that have came to Grove Clinicals with me, a lot of them have got to see cardiac caths and have really been excited, very intriguing. So if you'll look on page 657 on table 33-4, this talks about indications for a cardiac cath, how to prepare a patient for the cardiac cath, and then post-procedure. The doctor should talk to your patient about the cardiac cath, explain all the risks. Make sure your patient knows what they're going to be feeling when they get in there. They may have a hot flash as the medium goes into the vein or the artery in the heart. As the medium goes into the heart, they may feel like they need to cough. So those are just some different things that they need to be made aware of. And so you can read more about that. Post-op care is the main thing I want to focus on. You want to make sure your patient lies flat. You want to keep the insertion site extremity very straight. That could range from 2 to 6 hours. After a few hours, the doctor may be okay for you elevating the head a bit 30 degrees. Because remember, your patient is going to be NPO before the procedure. Once they're back to the room, they have to lie flat, but they're going to be hungry and they're going to be thirsty. And it's really hard to eat and drink when they're lying flat. So maybe after a few hours, they will be able to elevate the head a bit, about 30 degrees. You're going to do frequent vital signs on these patients. You're going to assess the site of the insertion, maybe for bloody drainage or a hematoma formation. And it's very important to check those peripheral pulses in the affected extremity. You also want to note the skin temperature and then the color. And then complications of a cardiac catheterization is going to be on page 658, table 33-5. And then this next slide, it just shows you where they enter on the artery and where the catheter goes in the heart. Okay, so that is going to, well, no, I have a question here, and then I think there's just a couple more slides. Which statement made by the client on the way to the catheterization lab requires an immediate action by the nurse? So you all can read through those answers, and you can shout out your answer if you feel like you know the correct answer.
B.
B, yeah. You don't, your patients have to stop. If they're on a blood thinner, they have to stop that a few nights, whatever the doctor says, before, because you don't want them to have bleeding issues when they're having their cardiac cath. So yeah, the answer is B. So let's look at, this is our last slide. Let's look at some other diagnostic assessments. Of course, an EKG, you may also see it ordered as an ECG. That's what we'll be talking about this afternoon. Provides information about cardiac dysrhythmias, myocardial ischemia. It also, doctors can tell the site and the extent of the MI off of an EKG. So, those are very important assessments that doctors use to help them in diagnosing and treating patients with cardiovascular disease. Electrophysiological study, I'm not really going to dwell on this one. It goes into the electrical stimulation of the heart. I just want you to know that may be done, but I don't really care that you know a lot about that one. A stress test. It's also, it can be a stress test or an exercise tolerance test. These are kind of the same thing. What it does is it increases the workload of the heart, and it helps the doctor determine the capacity of the heart and to screen for any asymptomatic coronary artery disease. So you may have heard this referred to as a treadmill test. So patients can be on like a stationary bicycle or a treadmill, and they walk, and they have leads on the patient's chest, and it just helps them to see how the heart reacts to stress. If your patients can't exercise on a bicycle or a treadmill, they can still do a stress test, which is done with medication. Usually it's done with dobutamine or persantine. And it is just medication that is given IV to patients, and it helps to stimulate the effects of exercise. The medication sometimes is not real pleasant. It's a vasodilator, and so it can cause flushing, can give patients headache, it can make them short of breath, it can give them chest tightness. My mom has had that before, and she said it was just absolutely horrible. But that is just another way that they can do that exercise tolerance test, the stress test, if they can't exercise. Then there's a TEE, that's called a transesophageal echocardiography, and it can examine the cardiac structures. It's a ultrasound transducer that's placed into the esophagus, and it can look behind the heart and give views of the posterior cardiac structures. And then we have the echocardiogram, which you all have already had that in your diagnostic test of the week for clinicals. So it's just an ultrasound of the heart, basically. It helps assess structures, mobility, and then it also looks at the valves. And then your myocardial nuclear perfusion imaging, that's just another scan that they use. And then your MRI. Okay, let's see if I have questions. Okay, there's a few questions that we can.
Julie,
Yes.
we do have another question. Which one specifically will you want them to know, and what to know about each one for the exam? So
Okay, of course, the EKG. Be familiar with the stress test or the exercise tolerance test, because you will have a lot of patients. You'll have a lot of patients that are admitted to the hospital for chest pain. Usually those are admitted under observation. While they're there, they'll possibly do a cardiac cath, or they may do a stress test or an exercise tolerance test. The echo, be familiar with that. And MRI, they're already familiar with that. So those EKG, stress test, echo, and MRI, those 4. And we'll talk more about EKGs this afternoon. Does that answer it?
is that good, Grace? Okay.
And I'm not going to test you over all of them. I think it's good that you're asking which ones you'll be tested over, but I want you to be familiar, because you're going to see a lot of lab work. You're going to see a lot of tests out there in the hospital. And I want you just to, at least if you're just familiar with it, understand the basics. It won't be foreign to you when you see it. Okay, so let's answer a few questions and then we'll take a break. A patient has recently been admitted with the diagnosis of CAD. What lab assessments would the nurse anticipate? Select all that apply. So this is where you're going to need to know your normals, your normal ranges for your medicines. So anyone have an answer?
A.
Well, they would do all of them except D, right?
No.
C.
The answer is B and C. That cholesterol is normal. The triglycerides are elevated. That would put them at an increased risk for CAD. Remember your HDL, you want it to be high. Remember, the higher the better for that one. So that's kind of low. I think that falls below the normal range. Everybody understand that one? Okay, on to the next one.
A question, Julie, on the test, are you going to specify if the patient is male or female? Are
If
there any questions that specific?
if it's necessary, yes.
So if it's necessary to specify.
Yes, because I know there are different ranges for males and females, so if necessary, yes. Okay, so the nurse is assessing a patient's heart sounds and has difficulty auscultating the first heart sound, S1. Which nursing response is most appropriate?
Getting lots of C's.
Lots of
C.
C's. That's right. You want to turn on their left side. Remember, that kind of puts the heart closer to the chest. Okay, while performing an admission assessment on a patient, the nurse assesses which of the following as risk factors for cardiovascular disease. Select all that apply.
C and F.
Okay. C and F, yes, exposure to secondhand cigarette smoke and family history. Remember, that's the most important, one of the most important risk factors, but there are a couple more.
Is B also, even though it's well controlled, it's still diabetes?
Yes, right. Diabetes, even though it says their diabetes is well controlled, it is still a risk factor because that is a chronic disease that they have.
Could E be one?
E is also one. Recurrent strep infection is associated with valvular disease. You may not have known that, but that's okay. So the answer is B, C, E, and F. The BMI of 22, that's a normal BMI. The blood pressure is okay. And then the cholesterol level of 140 is okay. So, okay. Next, we'll talk about ischemic disorders. It is 10 o'clock, so we'll come back at 10:10. Take a 10-minute break.
I think I'm gonna go take a. They've already been taken.
I'm gonna take a.
It looked like someone took a DUMP. They were going, did you see everything that Tori Winters is doing? Oh, there's been.
You're not on mute. You're not on mute.
Yeah, I have put in a.
You're not muted.
Joy Bauer, because they've already taught online about what their classroom etiquette is when it's a virtual classroom that we don't know. And I told her, I went back and looked at our video and saw Judy's person in the bed behind them. I saw Michaela in the bed. I've seen Callie Bell driving, and so anyway, we'll see whatever they say about it. So,
I need a response to this email.
what was it?
I need a response to this email. Go to,
Shorty's trying to call.
and then where it says,
She'll be sitting here and talking.
Oh, my.
Yeah, they heard us. She said, you're talking, we can hear you on here. I said, well, okay. And I'm saying, I don't know what we're gonna do, though. There is some problems that we're gonna have to handle. I have mine muted. Kathleen, they said it's you that's not muted, she said.
Continue recording. And I'm going to share my screen. And oops. Okay, Kath, does that look right?
Yes, I'm just seeing your PowerPoint slide.
Okay, great. Okay. So let's get into the ischemic disorders. That's going to be coronary artery disease, and that's going to include angina pectoris, and myocardial infarction, which is an MI. Page 768 is where these are going to be found. So let's talk about coronary artery disease. So you might hear coronary artery disease, you may see CAD, you may hear coronary heart disease, or maybe referred to just simply heart disease. Heart disease is the single largest killer of American men and women in all ethnic groups. Although the incidence of heart disease has declined due to increasingly effective treatment, and I think the United States as a whole has placed an increased emphasis on reducing the major cardiovascular risk factors. So when we think of CAD, that's just a broad term that includes chronic stable angina and acute coronary syndromes. So think back to your anatomy and physiology of the heart. When you have blood flow, it's going through the coronary arteries. When that is partially blocked or completely blocked, you're going to have ischemia, or you can have infarction of the heart. So ischemia is when there is an insufficient supply of oxygen to meet the requirements of the myocardium or the heart. Infarction is when you have necrosis or cell death that occurs when severe ischemia is prolonged and you have decreased perfusion, causing irreversible damage to the tissue. So when we're talking about chronic stable angina pectoris, this is chest pain that is caused by a temporary imbalance between the coronary artery's ability to supply oxygen to the heart's demand for oxygen. It's going to be a chest discomfort. Patients will normally describe it as a tight, squeezing, heavy pressure, constricting feeling in the chest. This pain can also radiate to the jaw, neck, or the arm. It occurs with moderate to prolonged exertion. Usually will only result in slight limitation of activity. It can be associated with fixed atherosclerotic plaque. Usually with chronic stable angina, it will last 15 minutes or less. This type of angina is relieved by nitroglycerin, which we'll talk about in a little bit, or rest. It can be managed with medication, rarely requires aggressive treatment. And remember, anginal pain is ischemic pain, so it will usually improve when the imbalance between your oxygen supply and demand is resolved. So that's just kind of a quick rundown of angina. And stable angina we'll talk about a little bit later. So when we have an acute coronary syndrome, this is used to describe patients who have unstable angina or who have had an acute MI. So it is believed that the atherosclerotic plaque in the coronary arteries rupture. This results in platelet aggregation, or they clump together, and then that forms a clot or a vasoconstriction. The amount of atherosclerotic plaque determines the degree of the obstruction or the blockage and the specific disease process. So an artery has to have at least 40% plaque accumulation before it starts to block blood flow. So that's kind of how MIs occur. So with unstable angina pectoris, usually it occurs with exercise, but it can also occur at rest, and it causes severe activity limitation. So this is kind of the opposite of the stable angina. It increases in occurrence, it can increase in severity and duration over time, usually will last longer than 15 minutes, and it is poorly relieved by rest or nitroglycerin. And when you think of unstable angina, it can be referred to as new onset of angina. This is when a patient has their first anginal symptom. Variant angina, I don't necessarily want you to remember this one, but it's from a coronary artery spasm, and it typically occurs after rest. You can also have a pre-infarction angina, which can occur days to maybe weeks before a patient has an MI. So patients with unstable angina, they can present with ST changes on a 12-lead EKG, but they may not have changes in their troponin level because the ischemia is present, but it's not enough to detect myocardial damage or cell death. So there might be some ST changes on the EKG, but they may not have changes in their troponin with the unstable angina. Okay, so let's talk about the most serious acute coronary syndrome, which is an MI. You might hear myocardial infarction. You might hear acute MI. So this is where the myocardial tissue is abruptly and severely deprived of oxygen. So when blood flow is reduced by 80 to 90%, and this could be caused by an occlusion, ischemia will develop, which can lead to an injury and necrosis of the myocardial tissue if it is not restored. Obvious physical changes don't occur in the heart until about 6 hours after the infarction. So early intervention is vital within the first 4 to 6 hours of symptom onset. And so that's just a real difficult thing for patients because, like I said, denial kicks in when they start having that chest pain. They think of every excuse it could be other than a heart attack. But damage doesn't really set in until after 6 hours. And so that's why it's vital that patients get treatment as soon as they can. Okay, this is just FYI for your information. This is how MIs are classified. They'll be classified according to the affected area of the heart. So they can be anterior, lateral, inferior, or posterior. And also according to the EKG changes that are produced. It could be a non-ST elevation MI. You'll hear that referred to as a non-STEMI, or it could be an ST elevation MI, a STEMI. And then it could also include the time frame within the progression of the infarction. It could be an acute, it could be evolving, or it could be old. So you won't be tested over that. That's just FYI for your information, because you will see when you have patients admitted with cardiac disease or have had MIs, you might see something dictated as on an EKG and old MI, something like that. So here again, when you're starting your assessment, a lot of this we've already talked about, so I'm just going to briefly hit some points that we haven't talked about. Atherosclerosis is going to be the primary factor in the development of cardiovascular disease. We've talked about non-modifiable risk factors, so I'm not going to hit anything there. Modifiable risk factors we've already talked about. I think we've hit everything there. I do want to point out that there is an increased risk of cardiovascular disease for older patients because they're more physically inactive. Usually as you get older, you have more chronic diseases like hypertension, heart failure, or diabetes, or you have specific lifestyle habits that make you more prone or more at risk for cardiovascular disease. Smoking and diet are one, and this is going to contribute more to atherosclerosis. So that's why you see more of the geriatric population that has a coronary artery disease. But I think all the others we've already talked about. Again, when you're doing your assessment, you're going to drill down on the history, your physical assessment, We've talked about pain. We've pretty much already talked about all of that. Troponin, remember we have the troponin T and I is going to be specific for your MI and cardiac necrosis. Thallium scan, I don't think we talked about that one. This is a scan that can assess for ischemia and necrosis. I won't test you over that one. I just want you to be familiar with it. The CTCA is a computed tomography coronary angiography. This is a fairly new procedure, but it's becoming highly reliable. I don't want you to know about that one either. And then we've talked about the other ones. Okay, so let's talk about some medications for pain management. These are on page 776, chart 38-4. Nitroglycerin, it might also come as Nitrostat, NitroQuick. It can also be a translingual spray. Nitroglycerin is a vasodilator that prevents coronary artery vasospasms, and it can decrease the myocardial oxygen demand. And it is used most frequently to treat anginal pain and to also help control blood pressure. So it's going to lower blood pressure, so you want to make sure you use it cautiously in patients who are already on blood pressure medication, because it can cause orthostatic hypotension. Some education for your patient that has chest pain. The client or patient needs to know to stop their activity and rest. They can place a nitroglycerin tablet under the tongue. It will dissolve quickly. Depending on how the doctor orders it, they can take it up to 2 more doses at 5 minutes apart if they continue to have the chest pain. Patients also need to know a common side effect of nitro is a headache. So they will most generally get a headache. And then because of the blood pressure, encourage them to sit or lie down slowly. Usually a stable angina will respond to nitro. If it doesn't respond to nitro, they would need to go to the emergency room or notify their doctor. Okay, morphine, sulfate, we've already talked about this, but morphine is given a lot for chest pain, also MI pain. It decreases myocardial oxygen demand. It relaxes smooth muscles. Remember, it also causes respiratory depression, and it also decreases gastrointestinal motility. So because of the respiratory depression, you want to use that cautiously in your patients who have asthma or emphysema. Usually a dose will be anywhere from 2 to 10 milligrams IV every 5 to 15 minutes. If they're having anginal pain or if they're having an MI. And then again, you want to monitor for the adverse effects, the respiratory depression. If their respiratory rate gets 12 or below, you want to stop giving that, notify the provider. A lot of patients can't take morphine. It causes nausea and vomiting. So if that would happen, you would want to stop and notify the provider as well. Oxygen, remember, oxygen is a medication. Don't wait to put it on your patient if they need it, but make sure you get an order for it. And of course, that's going to increase the oxygen available for the myocardial tissue. Position of comfort, patients will probably want to be in a semi-Fowler's to a high Fowler's position. And then make sure you provide a quiet, calm environment to manage their pain as well.
Haley, did you get the page number clarification that you needed?
Page 776 is pain management for an MI or chest pain. Okay, so let's move on. Increasing tissue perfusion, we're going to talk about antiplatelets. That's going to be your aspirin and your Plavix. Of course, these prevent platelets from forming together, which can produce an arterial clot. And it's going to decrease the likelihood of a thrombosis. Aspirin is a vasoconstrictor. It can be administered with the nitroglycerin. Sometimes your patients are on baby aspirin as well daily. Remember, aspirin or antiplatelet agents can cause GI upset, so you want to use cautiously in your patients that have a history of gastric ulcers. And then remember, a sign of aspirin toxicity is tinnitus, that is a ringing in the ears. So with your patients, you want to make sure they know they're going to have an increased risk for bruising and bleeding while they're on the medication. And then as far as joint commission, I know we've talked about core measures before, but there is an acute MI core measure set that all hospitals have. They are required to give an aspirin upon arrival to the ER or when the MI occurs if they have an MI in the hospital. So make sure if you have a patient that's had an MI, they are required to have an aspirin upon arrival. Beta blockers, Coreg, Lopressor, and Inderal, these are going to slow the heart rate. I know we've talked about beta blockers before. I'll just briefly hit on them here. It's also going to decrease the force of the contraction. In patients that have had an acute MI, these are usually given 1 to 2 hours after the MI. It can decrease the infarct size, and it can also improve short and long-term survival rates. So beta blockers, remember, those can cause bradycardia and hypotension. So you want to make sure you note the apical pulse before you give a beta blocker. If it is 60 or below, you would want to hold that and notify the provider. Beta blockers also can affect the respiratory system, so you want to avoid giving beta blockers to patients who have asthma or emphysema or chronic bronchitis. Let's talk about ACE inhibitors. Those are frequently ordered, ACE and ARBs, when patients have cardiovascular disease. ACE inhibitors are going to be your prils, your lisinopril, captopril, enalapril. They can, ACE and ARBs can increase survival rate after an MI. You want to make sure you monitor for urine output, hypotension, and a cough. ACE can cause cough. Looking at something real quick. Remember with your ACE inhibitors, and we'll go over these medications more in depth in the pharm lecture. You want to make sure you're aware of the potassium, because an ACE inhibitor can make a patient hyperkalemic. So make sure you are aware of that. And then on to our thrombolytic therapy. These are called clot busters, the Alteplase and Retaplase. That is ALTEPLASE, and Retaplase, RETEPLASE. These are used to break up blood clots, usually given within 6 hours of an infarction, and then they're just going to have similar side effects to the other thrombolytic agents that we've talked about. And then your anticoagulants, your Coumadin, heparin, and enoxaparin. These are also used to prevent clots or for preventing clots getting larger. You're going to monitor the PT, PTT, INR, and a CBC. Make sure your patients understand they need to decrease their risk for bleeding, so they may need to use electric razors while they're on this. You can monitor for signs of bleeding, peptic ulcer disease, anything like that. You would want to make sure you watch your patients closely on those. I know that was really brief on those, but I'm going to try to hit the pharm lecture here pretty quick. So with our patients that have cardiac disease or have MIs, you want to try to get them into cardiac rehabilitation. If they have prolonged weakness, maybe they need help increasing their level of activity. They can also go to pain management services if they continue to have uncontrolled pain. And then nutritional services, this would help them with diet modifications. They will possibly be on a low sodium diet, low saturated fat diet. You want to also help your patients discover maybe new ways to cope. Help them to identify new coping strategies or coping mechanisms, because remember, denial, patients may still be in denial. They may be angry because they have had a heart attack. Maybe they're not able to work like they were before. And this also causes them to have a lot of depression. You want to identify and manage dysrhythmias. A lot of times after patients have MIs, they have dysrhythmia. And so you want to make sure you're aware of this. The doctor, I'm sure, will be aware of it. A common dysrhythmia is bradycardia, which would be a low heart rate, and they may need a pacemaker. So just remember that as well. Complications of acute coronary syndrome, heart failure, which we will talk about on Thursday. That is a common complication after an MI. And also dysrhythmias, which we will talk about this afternoon in our skills. For some patients that have acute coronary syndromes, they could have a percutaneous coronary intervention. And this is invasive, but it is a non-surgical technique. This is usually performed around 90 minutes after acute MI. And this is where it's a combined procedure. They can remove the clot, they have a coronary angioplasty, and then they can have a stent placed. You don't have to be real specific, just be familiar with this procedure. This is what a stent looks like. It can be an expandable metal mesh device that's put in the stent, and then that's placed in the artery, and it helps to keep that artery open. And then the traditional surgery for an MI is a coronary artery bypass graft surgery. It's referred to as a CABG. This is a surgery that is seen probably more common in older adults. So preoperatively, sometimes patients will come in with a planned procedure, and then other times they're going to come in on an emergency basis. It's important that patients know how to splint their chest after surgery, because they are going to have to be getting up, they're going to have to be coughing, they will have a sternal incision. They need to make sure they understand to report any pain, because most of the pain they have is going to be the site where they harvest the vessel, where they do where they take the vein to put in the heart. And so a lot of the pain is going to be there, not the actual sternal surgery that they have. So make sure they understand they need to ask for pain medicine. It's okay to do that. During the operation, they are going to be put on a cardiopulmonary bypass machine, and that picture there just kind of gives you a sample of what's going to happen while they're having the surgery. Post-operatively, they're probably going to be on a ventilator. You need to assess for any arrhythmias, manage fluid and electrolyte imbalance. Other complications could be hypothermia, hypotension, sternal infection, and pain. And these are pictures of the different bypass grafts that they may do. There's two different grafts here that you can see, two different methods. So when patients go home after traditional bypass surgery, it's good to include case management, because these are very high cost surgeries, high volume, high risk patients. They may go home or they may go to the skilled. If they go home, you need to focus on self-management, education. patients that have these types of surgeries, they go home fairly quick, a lot quicker than you would think they would. So it's very important to start their self-management education as soon as possible. Risk factor modification, tobacco cessation, they may have to change their diet, regular exercise, blood pressure control. You can also do complementary therapy. That's going to be, pet therapy, guided imagery, different things like that. Drug medication or medication therapy, you want to make sure they understand about their medications, make sure they know the benefits, the side effects, when to take. You may have to, give them a calendar and write exactly their daily medications, just any way to keep them in compliance with their meds. They need to know when to seek medical assistance if they start having a low heart rate, if they have any wheezing, dyspnea, weight gain of 3 pounds or more in a week, if they're persistently still having to use their nitroglycerin, anything like that. They need to know that they need to immediately seek help. Okay,
Tori
Yes.
commented that her dad was discharged within 3 days.
Yeah, it's very, very quick. You think, oh my goodness, are they really ready to go home? So your education, all your teaching, that has to be done very quickly. It's very important to involve family as well, because so quick after surgery, patients are still going to be sleepy and kind of still have the effects of the anesthesia. So it's very important to involve the family as well. And the family kind of has to be pushy with the patients, because they may not feel like doing a lot, but they need to. Okay, I'm not going to go over these questions. I want to go on to our pharmacology. Whoops. I want to go, I'm having issues here. I want to go on to our pharm lecture. So let me share this one. And if I don't happen to get through this, maybe we can finish some of it in skills today. Okay, so can you see my slide?
Yes.
So this first one is the nitroglycerin. I think we've pretty well covered that one quickly. Remember, patients are going to do this when they have chest pain. It's just a small little tablet that goes under the tongue for angina. It's also used to control blood pressure. I don't think there's anything else I want to say. Remember, you have to watch blood pressure on this, because it will drop it. If they are on blood pressure medication, it could drop them too low. So that's all on that one. Beta blockers. There's the medications that you need to know. Make sure you monitor their blood pressure and pulse, because it can cause bradycardia and hypotension. Also important to know is beta blockers can mask hypoglycemia in patients who have diabetes. So you want to be careful with your patients that are diabetics, because it can cause them to have very, very, very low blood sugars. And it could cause their blood sugar to drop, and that's going to be before they have that hypoglycemic warning, which that's going to be tremors, tachycardia, sweating, those types of things. You also, again, want to watch this in patients with asthma, because it inhibits bronchodilation. So you want to watch this when you give it to patients if they have asthma. I think that's all I want to hit on with beta blockers. Here's just a little picture that talks about the beta blockers. Okay, calcium channel blockers. There's your medications listed there. Make sure you monitor blood pressure and pulse. I think everything is listed on there that you need to know for those calcium channel blockers. Here is another picture that talks about calcium channel blockers. Okay. Clonidine is a medication that is used to decrease blood pressure. This medication is not first-line management of hypertension. It is for severe hypertension, can be given. Everything is listed on there that you need to know. Make sure you monitor their blood pressure, obviously, and their pulse. Antiarrhythmic atropine. It's used for bradycardia. Its effect, it's going to increase the heart rate. So you would want to monitor their heart rate and rhythm after you give atropine. Antilipimics, the lipid lowering, the Lipitor and the Zocor. It's going to relieve manifestations associated with peripheral arterial disease, which we will talk about this afternoon. So it's used to lower cholesterol, is what it's mainly for.
Julie, Odessa said that the doctor has her daughter on clonidine for sleep. Is that normal?
It can cause sleepiness. That is a side effect, is sedation. So yes, it can cause sedation. I can't answer that it's normal for her to be on it, but it does cause sedation. Okay, let's go on to antiplatelets. Aspirin, I think we talked about aspirin pretty in detail. It's usually given with nitro, can cause GI upset. Make sure your patients know that, you know, their blood can get too thin and it can cause them to bleed. So they need to be aware of that. Watch for bleeding. Plavix, it can be given after a stent placement, and then report any side effects of bleeding or nausea and vomiting. You can take it with a meal to decrease the gastric upset. Okay, anticoagulants, your warfarin or Coumadin. Therapeutic effect can take 3 to 4 days to develop. So usually the administration of warfarin is going to be started while the patient is getting IV heparin. So if a patient comes in with blood clots, they're going to be put on heparin first. Then after their level gets to where the doctors want it, when patients maybe are closer to going home, the doctor will keep them on the IV heparin, start them on the warfarin or the Coumadin, and then eventually take them off of the IV heparin, and then they'll go home on the warfarin or Coumadin. So as with any anticoagulant, you're going to monitor for bleeding, monitor their PT and INR. Make sure you know what the antidote is for warfarin or Coumadin, and that's going to be vitamin K. Make sure you have that available for your patient while they're in the hospital in case they have an episode of excessive bleeding. Make sure your patients understand the sources of vitamin K and to avoid a large amount of the food sources. That's mainly going to be your green leafy vegetables. Make sure they can still eat those, but just not a high amount, and don't eat them a lot. Anytime your patient's on anticoagulants, they need to be taking bleeding precautions. That's going to be maybe using an electric razor instead of a regular razor. Use a soft bristle toothbrush. Maybe if your patient's younger and active, no contact sports. Watch for injuries closely for excessive bruising, prolonged bleeding. I know my dad is on Coumadin. He hit his leg on something and went for days. And by the time I noticed it, he had bled into his leg and just had a huge hematoma. He wasn't aware that, he needed to stop maybe his Coumadin for a few days. So by the time we got to the doctor, it was just a big mess. But so make sure your patients understand that they need to take those bleeding precautions and watch for that. Unfractionated heparin, that's what is going to be given IV if a patient comes in with a clot, so to say. The antidote for heparin is protamine sulfate, so you need to make sure you have that available for your patients in case they start bleeding. Kind of all these anticoagulants are going to have the same things that you're going to need to watch for. Lovenox, which is your low molecular weight heparin, the enoxaparin, it's given subcutaneously and it's based on a client's weight. I do want to point out, I think it's on here, it's based on their weight in how the doctor orders it, but you would never want to give more than 90 milligrams of Lovenox. So even if their weight, you take their weight times a dose. I can't remember what it is. It's in one of my other PowerPoints that we'll go over. Even if it comes out to over 90 milligrams, you never want to give more than 90 milligrams of Lovenox. And many of you have already started giving Lovenox. Its therapeutic effect can take 3 to 4 days. So sometimes they're still on the heparin when you start the Lovenox as well. Usually when they're on Lovenox, you don't have to have the lab work. That's one advantage to being on the Lovenox versus the warfarin or the Coumadin. And then again, your patients need to take those same bleeding precautions.
Julie, how in depth do the students need to study all these different meds? What specifically do they?
Definitely know what they're for. And if you know what they're for, you're pretty much going to know what to monitor for. You know that, these anticoagulants are going to make the blood thinner. Obviously, you're going to, need to watch for bleeding, instruct your patients on bleeding precautions, those types of things. Make sure you know the antidote for the anticoagulants. Okay, we've already talked about the Alteplase and the Reteplase, so I'm not going to talk about those again. You will not be tested over these. These are not real common, and they'll mainly be given in the ER.
2 more questions, Julie. What happens on the Lovenox if not, was that Lovenox 90? Yeah, 90. What happens if more than 90 milligrams is given? I don't know if you know the specific answer.
I don't know that I know the answer to that. I just know instructions on the Lovenox said that you don't ever want to give a dose higher than 90 milligrams.
Probably would just...
you would have to really monitor them and
yeah.
monitor them for their bleeding, because they could bleed easier if they're given too high of a dose.
And then the other question is there an antidote for Lovenox?
Yes, it is protamine sulfate.
That is it Protamine?
Protamine sulfate.
Protamine sulfate.
Yeah.
So heparin and
protamine sulfate is the same for heparin and the
For heparin, yes. Coumadin and warfarin, the antidote is vitamin K.
okay.
Okay, I think we've gone over the ACE and the ARBs fairly thoroughly. Just remember when you're given an ACE inhibitor, make sure you're aware of the potassium because it can make your patient hyperkalemic. Make sure you monitor blood pressure and pulse. Remember, ACE is the one that causes a cough. So that needs to be reported if the patient has a cough, and the doctor could probably switch them to a different medication. Another picture, ARBs. These are what they can be switched to if they're taking an ACE that's causing a cough, or it causes them to have hyperkalemia. Mm-hmm. Okay, diuretics, hydrochlorothiazide. Of course, these make you get rid of excess water. The loop diuretic, which is your furosemide, your Lasix. Remember it, when you're getting rid of water, you're also getting rid of potassium. So your Lasix can cause a low potassium. Opposite of that is your potassium-sparing diuretic, the spironolactone. It causes you to hang on to potassium, so it can cause a high potassium. So anytime you have a diuretic, you want to monitor the potassium level. When you have a low potassium, you know you're going to have muscle weakness, maybe an irregular pulse. So make sure you understand what a low potassium is going to show, as well as a high potassium. I think that's it on diuretics. Vitamins, just be aware, folic acid is for the treatment of anemia. Some patients might be on vitamin B12 with cardiac disease, and then iron also for anemia, the ferrous sulfate. Okay, questions? I know that was a lot, and we're going to get more this afternoon. Fast and furious. Any questions? No. Okay, so we will come back at 1 o'clock. We'll talk about dysrhythmias, EKGs, different heart rhythms, and then we'll talk about peripheral vascular disease and arterial disease, and cover a few other things, and nutrition. If you will look on D2L under your theory, there is a homework assignment. It is a case study for angina. So you can print that off. I think there's 4 or 5 questions that pertain to the little case study on the patient. Due date. Let's see, what is today? Tuesday. Let's have that due let's have it due by Friday, April the 3rd at 9 o'clock. So if you have a printer, print it off. You can handwrite your answer, and then you can scan it in by your phone. The instructions I gave you earlier, and I will put a Dropbox in D2L. If you don't have a printer, email me and I'll tell you what to do. But hopefully you all have a printer and can write out the answer. If you don't have a printer, you can just write answers out, number questions, 1, 2, 3, 4, 5, answer them, and then scan them in the same way and drop it in the Dropbox.
Where did you say that was located?
It is on D2L under assignment or under content, under the cardiovascular tab. It'll say a case study angina assignment, something like that. I put it on this morning.
So we can't just like type it in on the Word document that it's already at and just submit that to the Dropbox?
I guess you can. I just don't want you to copy and paste answers, because the whole point of the assignment is to understand what you're writing, not to copy and paste information. So I'll let you type it, but if I see you copy and paste it, you're going to be in trouble. This assignment is going to be worth, I think, 7 points. I think we've already had 8 points, so it'll be worth 7 because we have a total of 15. So, any more questions?
How do we scan items with our phone?
It's
Well,
Coco Mama.
That's
Coco.
Coco Mama, and I see her funny picture there. So remember, you go to your Notes app on your phone, and you're going to just hold your finger over it. And down there towards the bottom, it says Scan Document. You're going to click Scan. You're just going to take a picture of your document. And then once you take a picture, you're going to click Keep Scan. So you keep the scan. Then it'll say ready for next scan. So if you have more than one document you're wanting to scan in, you can do your second document. If you're finished, then you click save. It's going to save it, and then up at the top of your phone is a square with an arrow up. You're going to click that, and you can send it to your neo.edu email address. Once you put it in your email, you can save it on your laptop in a folder, and then from there you can put it in the Dropbox on D2L. I believe those instructions either have been emailed or they're on D2L. If they're not, I'll make sure they're there.
I believe they're on D2L in that V folder.
Okay.
I think those instructions are listed there.
If you have any problems, just let me know in scanning. I've done it myself and it does work. So if you need a scanner, it's a quick way to have a scanner instead of trying to find one.
Coco Mama thanks you.
Oh, you're so welcome, Coco Mama.
Just a reminder too, I think Vicky's doing a open Zoom meeting. It's not mandatory, but if anybody has any questions, I think she's planning on being on 11 to 12. Did everyone invite to that? I don't know if she sent an invite or if there's a way to join, but she told me she was doing that at 11 o'clock.
Yeah, she sent an email. It's the same like link every time, she said.
Okay.
Is
Okay.
the link for this afternoon the same?
You received a separate email. I sent it right after I sent the one for this morning. It says it was sent on Sunday morning around 8:15 in the morning. And it says it starts at 12:30. And that's just, if you want to join early, we won't start until 1 o'clock.
And what about tomorrow for the ones that are supposed to be off? So we don't have to join in the Zoom?
If you have an off day, no, if you don't have anything to make up, you won't join in tomorrow. And Kathleen, you're going to talk this afternoon about clinicals. Yeah. So we'll talk this afternoon about clinical. Any more questions? Oh, yep, I'm still recording. That's okay. Thank you, Tristan. Okay,